So, Lenny, it really is a privilege to go second to last because it gives me the chance to actually close down what's been a fantastic conference. So thank you for the invitation. And Lenny has charged me with discussing survivorship of childhood ALL, lessons from the Childhood Cancer Survivor Study, and what's specific about ALL and survivorship. And so as principal investigator, I ought to be able to do that, but I want to say first that I stand on the shoulders of Les Robison, who founded the study 20 years ago and has led the study for the last 20 years. And so I'm very grateful for the opportunity to now step in. So my goals for this talk are to quickly, over a very short time, define the need for a survivor cohort. This has been a conference centered around a very small population of people with a very rare disease, so having a large survivor cohort, you can imagine, would be essential for studying late effects. But I also want to describe the risk for long-term effects from standard risk ALL and its treatment, and the hopes that we've now identified a population who's doing much better than the average survivor. And then finally, I want to then talk about the oldest of the ALL survivors and describe the long-term cognitive risk for aging survivors who receive cranial radiotherapy. So let's start with the big picture. We now cure 80% of children who have cancer, and as of 2013, there were 420,000 survivors in the United States. This was an estimation. And then it's projected forward that by 2020, there'll be over 500,000 survivors of childhood cancer. When you look in the age group, 20 to 50 years of age in the United States, 1 in 680 persons is a survivor of childhood cancer. So what that means now is that you walk into the local mall or you go to Fashion Island tonight for dinner, you're going to be in and around survivors of childhood cancer. They're now a ubiquitous part of our population. That being said, there's still a small population, and so it's essential to have a large cohort to move forward with evaluation of late effects. There simply are limitations to any single institution's number of patients, a small sample size, and then the ability to follow these patients through adulthood is simply just non-existent through most routine children's hospitals. So thus, the Childhood Cancer Survivor Study was initiated in 1994. It is a retrospective cohort study of 5-year survivors of childhood cancer diagnosed between 1970 and 1986. Included in this is leukemia, along with a lot of other common childhood cancers. There were over 20,000 that were initially eligible for this study. 17,000 were contacted, and ultimately 14,372 participated. That's a 70% participation rate in this cohort. And we now have stored DNA in over 8,000 of these participants. But I'm also happy to announce that as of this month, we've expanded this cohort to now go beyond 1986. We're now including survivors diagnosed 87 through 99. We've added an additional 10,000 survivors to the cohort. So the overall cohort is now 24,000 survivors diagnosed across 3 decades of time. So imagine now what that means for ALL from 1970 to 1999 and all the evolution of therapy and now the opportunity to understand how changes in therapy have impacted long-term survivorship. So just a brief touch on the methodology. For this cohort, this is a survey-based study. And so every survivor has participated by completing a baseline questionnaire and 5 subsequent questionnaires. In addition, and what's key with this study is we have detailed treatment information. We went to all 26 institutions that participate in the study, abstracted directly from the medical record every chemotherapy, cumulative dose, and the radiotherapy dose. And then through the MD Anderson at our Radiation Dosimetry Center, calculated organ-specific ART radiation dosimetry for evaluation of toxicity. In addition, we have a repository with buccal cell DNA on over 8,000 members of the cohort. We have a pathology center where we confirm secondary neoplasms. We use the National Death Index to look at mortality. And then finally, and very importantly, a comparison population. We have a sibling cohort of over 4,000 siblings of these survivors. They give us the opportunity to really understand, is what we're seeing different than what the general population may be experiencing? Now, when you look at this population, they're widely distributed across the United States and Canada. This is the original 14,000. And so this is a survey-based cohort. So let's dig into the data for the entire cohort before we focus in ALL. For the entire cohort, in one slide, I can summarize the message of survivorship, and it's this slide, cause-specific mortality among aging survivors. And so this point right here is the 5-year point, the point of 5-year survival. This is where we walk into the room and throw the confetti and celebrate the fact that they beat their cancer. But here's what happens from a mortality standpoint beyond that. The blue curve is death due to recurrence or progression of primary disease, and you can imagine that this plateaus with time, and it certainly does. The gray curve is death due to external causes, so accidents, injuries, trauma, suicide. Very low, less than 1% over time. But look at this gold curve. This is death due to non-recurrence, non-external causes. These are all other medical causes of death. And look what happens. 25 years out, there's an inflection in this curve, a change in this curve. And this is the mystery of long-term survivorship. What is going on at 25 years out that all of a sudden the mortality for this group increases? And I assure you this is a greater than what you'd expect in the general population. And all being, while these survivors are only 25 years from diagnosis, they're in their 30s, they're in their 40s, they're still quite young. Well, let me show you what's going on. And you need this before we dig into ALL. These are largely attributable to death due to subsequent malignant neoplasms. Our long-term survivors have a 15-fold increased risk for death due to second malignant neoplasms and a 7-fold increased risk for death due to cardiac toxicity. So the two great enemies of our aging long-term survivors are subsequent neoplasms and cardiac disease. And this plays out not only when you look at mortality, but when you look at underlying chronic health conditions. And like you, we use the CTCAE criteria to grade our health conditions. So we looked recently at the CTCAE grade is 3 through 5. So these are severe, life-threatening chronic health conditions, including mortality. And as you can expect, by 20 years of age, 20% of survivors have had a severe or life-threatening event, compared to only 3% of siblings. But now let me remind you before I show you the extension of these curves that a grade 3 through 5 event, this isn't hypertension or dyslipidemia. This is MI, heart failure, this is pulmonary failure, renal failure, blindness in both eyes. These are severe and life-threatening events. So what happens as you follow them out through time? Actually, while siblings develop chronic health conditions, they never catch up with survivors. The gap between survivors and siblings widens with time. And this is an important fact. The second important fact from this data is for the first time we understand what a 20-year-old survivor of cancer looks like. They have the same risk for chronic health conditions, the same cumulative incidence as a 50-year-old sibling. And that's exactly what we see in clinic when you start looking at the medical record, long lists of chronic health conditions. So surely there's got to be some good news here. And in fact, I think there is. And I think the good news comes from what you've done over the last 20 to 30 years by identifying low-risk subsets of patients with ALL and reducing their therapy. And what I want to show you now is a new publication published just a few months ago in Lancet Oncology, led by Stefan Essig and Paul Nathan, that identified our low-risk subset within our study and looked at their long-term follow-up. So in this study, Paul and Stefan looked at 5-year survivors of childhood ALL diagnosed between 1970 and 86, who were between 1 and 10 years of age, and they limited just to those survivors who received therapy similar to standard risk therapy in more modern era. So they were survivors who had no cranial radiotherapy, had less than 120 milligrams per meter squared of anthracycline exposure, and less than 1,000 milligrams per meter squared of cyclophosphamide. Within our population, that was 13% of the ALL survivors, 556 patients, and then they compared these to over 2,000 siblings. So first, mortality in this population. This is with a median follow-up of 18 years and a median age at last follow-up of 27 years, so they're almost 30 years in age. If you look at the number of deaths in this population, there were 28 total deaths. And the SMR, the standardized mortality ratio, is really the observed to expected ratio. So there's a 3.5-fold increased risk for mortality in the standard risk ALL population compared to that expected in the general population. No difference between males and females. And importantly, as they moved on from diagnosis, by the time they're 20 years out from their therapy, the risk of death is essentially that of the background rate in the population. But importantly, what they discovered is there was no significant increased risk for death due to either subsequent neoplasms or cardiac disease. And that's very different than the entirety of the population and a significantly important finding. And as you can imagine, largely attributable, as we could bet, to the reduction or the elimination of cranial radiotherapy and the lowering dose of anthracyclines. So what about subsequent neoplasms? Well, there were very few. In this population of over 500 patients, there were 6 total subsequent neoplasms, 2 melanomas, 1 astrocytoma, a large cell lymphoma, 1 myeloid leukemia, and 1 hepatocellular carcinoma. The standardized incidence ratio, again, the observed to expected ratio in the general population, 2.6, so a slightly increased risk. But overall, a very low number of diseases, of malignancies. And if you compare to this to a radiated population, you would have seen a large number of meningiomas, a higher number of high-grade gliomas in this population. So this is actually very, very impressive results. They also explored the cumulative incidence of chronic health conditions. This is the same curve, the second curve, grade 3 through 5 health conditions. And you can see this time, siblings and survivors are very comparable, 16% at 35 years compared to 9% at 35 years. But what about specific chronic health conditions? And these are the ones you know that these survivors are at risk for. So again, heart failure attributable to anthracycline therapy, stroke attributable to cranial radiotherapy. These have been eliminated, and look what happens. The odds ratios for cardiomyopathy and heart failure, 1.5, not statistically significant. Stroke, 3.3, but not statistically significant. In fact, there was no increased risk for hypothyroidism or obesity in this population with the elimination of cranial radiotherapy, and only for osteoporosis and short stature was there a significant difference between survivors and siblings. And then finally, maybe the most important outcome of all, how are they really doing out there in the real world? Sociodemographic outcomes. So they looked at, Paul and Stefan looked at household income, college education, whether they were single or married, and whether they were able to live independently, and saw no difference between survivors and siblings. So a pat on the back to you, good job. Your decades of work, I think, now are showing, and will show as more research goes forward, that we've done a great deal to improve survivorship for standard risk ALL. But let's shift our focus just for a minute to late neurocognitive outcomes in the older population, those who received cranial radiotherapy, because this number of patients is not insignificant, and they are aging, and at increased risk for new complications. And so if I were to point you to one paper to really understand the cognitive impact on this population, I'd point you to this paper by Kevin Krull from last year. And now this is not a CCSS paper. This is a paper from one of our other important cohorts, the St. Jude Lifetime Cohort. And Kevin looked at the survivors from St. Jude who were all at least 10 years from diagnosis and greater than 18 years of age, so all adults. And within this group, there were over 560 survivors of ALL, a median age of 33 years, so similar to the previous study, and a mean time of 26 years from diagnosis. And as this first curve shows, if you look at executive function, I realize that is small. The blue curve is those who received 18 gray cranial radiotherapy in this period, and the yellow curve is those who received 24 gray. And that with time, that 24 gray population has an increasing risk for impairment in executive function. And I'm just showing you executive function. But Kevin, and I want to refer you to this paper, exhaustively looked at this population. And what was important is he had patients who had 24 gray, 18 gray, and then no cranial radiotherapy, and was able to compare cognitive outcomes. And so I won't spend too much time on this table, but look simply at intelligence. 24 gray, 23%, 1 in 4 of the population have impairment that is 2 standard deviations below normal in IQ or intelligence. Now with 18 gray, that number is reduced to 12.3%. And then in the era of no cranial radiotherapy, that number is still not normal. It's 9%, but it's much lower. And so this speaks to the fact that over time, with the reduction of cranial radiotherapy, we've seen improvement in neurocognitive outcomes. But there are still new questions to be asked, and one that we wanted to raise had to do with dementia and the risks for dementia as this population ages. And so this population is now aging through their 40s and 50s. And are they at risk for early onset of dementia compared to populations who didn't receive cranial radiotherapy? And it's well established that patients or children who have traumatic brain injury or whole brain injury during childhood are at increased risk for dementia. So we wanted to raise the question, radiation exposure during childhood is a whole brain injury. What is their risk, and can we define it? And so far, that really is not known. So our primary aim in this study, again through the St. Jude Lifetime Cohort, was to estimate the prevalence of memory impairment and dementia in these aging adult survivors of ALL who received cranial radiotherapy. And our hypothesis was that delayed memory impairment, and by delayed memory, meaning specifically 20-minute recall, like you'd see in a dementia population, it would be more common among survivors than in age-standardized norms. So this population included 138 patients who received 24 gray and 127 patients with 18 gray. And their age at cranial radiotherapy was very similar, but their time from therapy, as you would imagine, was quite different, 34.5 years versus 25.6 years. But I want to draw your attention to the very bottom line, which is full-time employment. For both of these groups, the full-time employment was 63% for either group. So we did this using the Wechsler memory scale, and we decided that impairment would be an age-adjusted score more than 1 standard deviation below the normal mean. And the Wechsler memory scale is different than most studies that have been done to date. Most studies to date have looked at global IQ, working memory, processing speed, attention. But this really gets into delayed memory, like you'd see or use or measure in an aging dementia population. And so these two immediate memory and delayed memory indices give us that ability to look at 5 and 20-minute recall on an abundance of memory scales. To assess dementia, we use the brief cognitive status exam. That's very similar to many mental status exams, so serial 7s, orientation to time, place, person, that sort of thing. And then finally, we looked at full-scale IQ. So in regards to memory impairment, when we looked at immediate memory and then delayed memory, again, 20-minute recall on the same task provided after immediate memory, those with 18 gray did quite well. But those with 24 gray radiotherapy, actually 33% had impairment in immediate memory and 30% impairment in delayed memory. And when you dig into this, it becomes very interesting. So for the 24 gray population at a mean age of only 41 years of age, when you look at the specific subsets such as logical memory, so that means narrative memory, the ability to hear a story, so a paragraph, retain it, recall it, and then answer questions, that's narrative memory. Our survivor population completed only 35% of the answers correct. They should have, for their age, completed 45%, and they finished at a comparative age level of 70 years of age. So 40-year-old survivors finishing and have a narrative memory of a 70-year-old. They also looked at design memory, verbal paired associations, and visual reproduction. And for those last two groups, these 40-year-olds finished with scores similar to what we'd expect a 50 or 60-year-old to have. So certainly some advancement in some specific areas. The brief cognitive status exam, this is our mini mental status exam. Again, survivors who had 24 gray, 18% failed this test, way beyond what was expected. So what is going on and what is memory? And so memory requires a lot of different portions of the brain working together. Processing of sensory input through the temporal and occipital lobe. New memory formation also then requires encoding and processing through the hippocampus. And finally, pulling back memory, so this 20-minute recall requires memory storage and retrieval through the frontal and parietal lobe, all of these functioning together. So we also hypothesized that if you started looking at these brains by imaging, that we might see, in fact, 70-year-old brains. So we want to determine whether impairments that we saw on testing were associated with neuroanatomical regions that are commonly affected with aging adults with dementia. And so our hypotheses were those with immediate memory would have impairment in temporal lobe and hippocampal volume, but those with delayed memory would have impairment in frontal parietal cortices as well as the hippocampus. And for time, I can't really show you all these data. I'll just show you the hippocampal volumes, which were measured by MRI, and show you that while the left side of the hippocampus was fine, patients with both immediate and delayed memories had smaller right-sided hippocampi. That's very similar to what you'd see, again, in an aging population developing dementia. And so when it comes to our hypotheses, here's what we found. For immediate memory, all of our hypotheses were substantiated. We saw temporal lobe atrophy, temporal lobe parietal white matter integrity reduced, and hippocampal volume loss. And then for delayed memory, again, hippocampal volume loss, but thinning of the frontal and parietal cortices. Taken all together, again, these brains of 40 and 50-year-olds looking like 70-year-olds. So consistent with an early onset of aging. So a few conclusions about these data. Memory and mental status impairment were observed after 24 gray cranial radiotherapy in this aging group, but not after 18 gray. Doesn't mean that 18 gray is safe, it just means we haven't followed them as long and they did get a lower dose, but further follow-up is warranted. For certain delayed memory domains, our survivors are functioning at a cognitive age 1 to 3 decades beyond their chronological age after 24 gray exposure. And then finally, structural and functional neuroimaging corroborate the impairments that we measured with anatomical regions established as for memory and encoding and recall. And it really does begin to paint a picture of an early onset of cognitive aging in some of these survivors. So with that, I want to close. I want to remind you that the Childhood Cancer Survivor Study is a resource, an open resource funded by the NCI for all investigators. So as you think about changes in therapy across the decades and the potential change in late effects, this is a resource that's potential for you to use. I look forward to hearing from you if you're interested in the cohort, and thank you for the opportunity to speak.